All right, welcome everyone. Today we're going to walk through a case that you are absolutely going to see time and time again on the wards. This is one of those classic presentations that really connects what you've been learning in the textbook with what you'll see in a real-life patient.
So I want you to meet Kevin. He is a 52-year-old accountant, and he came into my clinic just the other week. He's got a strong family history of diabetes and lives a pretty common lifestyle for many of our patients. He just looked, well, he looked tired. He was worried. He told me, "Doc, something just feels off."
And, his own words really paint that textbook picture of hyperglycemia, right? But as you're about to see, that's really just scratching the surface of what's going on.
So here's our game plan. We're going to walk through Kevin's case just like you would on the floor, from the moment he walks in all the way to his long-term management plan.
All right, first things first, let's start gathering our clues. We need that subjective and objective data. So, the history and the physical exam. Okay, now this is really interesting. What you see here is how Kevin's history, that's on the left, directly shows up in his physical exam findings on the right. So for instance, you see his diet, high in processed foods. Well, that directly contributes to what we find on exam, his class 2 obesity and that central adipocity we measured. It's a perfect example of how lifestyle choices become real, objective clinical signs you can see and measure.
I like to think of it this way. The family history, that loads the genetic gun. But it's his lifestyle choices, that sedentary job, the diet high in processed foods, that's what's actually pulling the trigger.
And look at this. This is a brilliant illustration of a key physical finding. I'm telling you, do not miss acanthosis nigricans on a skin exam. It is one of the strongest external clues you'll get for the insulin resistance that's happening on the inside. Okay, so we've got a compelling history and some key physical findings. Now what? Well, let's see what the lab evidence tells us. Let's see how this really builds our case. So we ordered a pretty standard panel, and the results, well, they were definitive. You can see right away there's a lot of red on this screen. His fasting glucose is way up. Triglycerides are significantly elevated. And look here, we're already seeing early signs of kidney damage with that microalbuminuria. But here's the kicker. The hemoglobin A1C, remember, that's our 3-month average of his blood sugar control. And his? It's 8.1%. That is well above the 6.5% cutoff for diagnosing diabetes. So this confirms what we suspected. So yes, this absolutely confirms our main diagnosis, type 2 diabetes mellitus. But, and this is critical, you have to see this as part of a bigger picture. It's really metabolic syndrome, and we're already seeing some of its complications. So, we have the what, we have the diagnosis, now we need to understand the why. What's the underlying mechanism here? Why exactly is this happening to Kevin? Okay, so type 2 diabetes really boils down to this dual defect. Think of it in 2 parts. First, you have insulin resistance happening at the cellular level. This means his tissues, like muscle and fat, just aren't responding to insulin the way they should. Now, because of that resistance, the body tries to compensate, and that leads to the second part, relative beta cell dysfunction. The pancreas goes into overdrive, pumping out tons of insulin, but eventually, it just can't keep up. And I really want to drive this point home. This is not just a pancreas problem. It's a systemic issue. It involves the liver, the adipose tissue, the kidneys, the gut. The whole system is involved. And that's exactly why our treatment plan has to be multifaceted.
Okay, so how do we tackle this? Our plan has to be comprehensive. We need to address both lifestyle and pharmacology.
We're going to structure our plan into 3 clear, logical steps. And we're going to start with the absolute foundation of all diabetes care. These are the cornerstones: dietary changes, getting more physical activity, and really good structured patient education. Let me be clear, these are absolutely non-negotiable for any chance of success. Pharmacologically, we're going to start with metformin. This is the first-line agent for almost all patients. Why? Because it works mainly by telling the liver to chill out on producing so much glucose, and it has an incredible track record for safety and efficacy. But here's the next question you have to ask yourself. Given everything else, his family history, his hypertension, his dyslipidemia, is metformin going to be enough? What else can we do? What else should we do to protect his heart and his kidneys? So if you look at the treatment algorithm here, Kevin's path is pretty clear. His high-risk profile basically demands that we add another medication, specifically one with proven cardiorenal benefits. The 2 big classes you need to think about here are the GLP-1 receptor agonists and the SGLT2 inhibitors. And what's so great about them is that they do more than just lower blood sugar. They actively protect the heart and kidneys.
Okay, last part. Let's talk about the long game here. And more importantly, what this all means for you, as you're about to start caring for patients just like Kevin.
Your job on the wards is going to be vigilant surveillance. You have to be on the lookout for complications. So for Kevin, you can see here, we have an urgent need for an eye exam. And that warning about his cardiovascular risk, that's not a suggestion. It's mandatory to address it.
So, to wrap this all up, here are the crucial points I want you to carry with you to the wards. First, type 2 diabetes is a systemic disease. It is not just a glucose problem, so you have to treat the whole metabolic syndrome. Second, always connect the patient's history and lifestyle to what you find on their physical exam. Third, remember acanthus nigricans. It's a huge clue for insulin resistance. Fourth, for high-risk patients like Kevin, you have to think beyond just metformin. You need to consider those agents with cardiorenal benefits, like the GLP-1s and SGLT2s. And finally, never forget that patient education is just as powerful, just as critical as any prescription you'll ever write.
So, as you get ready to head into the hospital, I want you to think about this. How are you going to apply this kind of clinical reasoning to the very first patient you see with diabetes? Because I promise you, your patients are counting on you to get it right.